This is the instructional video for vibratory PEP or oscillatory PEP. It may be called VPEP or OPEP therapy in a facility. There are lots of different devices that you can use for this therapy. It's kind of, I usually tell my students that it's like calling all tissues Kleenex. A lot of places they refer to it as flutter valve. So in reality, flutter valve is this device. The kind of common name you might hear it referred to as is the pipe. It kind of looks like an old-fashioned pipe when people smoked pipes. This device is the flutter valve. That's its brand name. A flutter valve it's pretty simple, just a hard piece of plastic. There's a little cone that goes inside of it. There's a heavy metal ball that sits in there, and we tighten the top. You can see it's just a simple plastic device. I'm not able to control the amount of PEP, positive expiratory pressure, that can be delivered. It just by default, with it being a little bit of a restrictor, probably delivers a little bit of PEP, but this is primarily a vibratory device. Patients will use it in the same way that I'm going to teach the patient with my device. But it's primarily just for vibration. But you'll find a lot of places call all vibratory PEP flutter valve. There are a lot of different devices. We have the VPEP by Dr. Burton that you may see. Things that I like about this one, you can really take it apart and get a lot of the parts of it clean. Any of these devices really can be washed in mild soap, which would be like Dawn dish soap, and left to air dry. You may see manufacturers recommending placing on the top shelf of a dishwasher. I personally would not recommend that. There's just so much dirt and grime in a dishwasher. I would never put something in my mouth that had been washed in a dishwasher and breathe through it. This is one version of the acapella. A lot of places around here use it. The only part you can remove here is the mouthpiece, and clean with mild soap. Oh, and the acapella, you can change the intensity. There's a plus arrow, minus arrow, so you can turn it up or turn it down. That will increase PEP and vibration. This is just another example. It's called the VibraPEP. I like this one. It has a nice handle to hold on to for the older folks that might have arthritis in their hands. The one that I'm going to be working with today is the Aerobica. I really like this one. We don't use it at the hospital system I work at, but I like it. This one you can also take all the way apart. You can take the mouthpiece off. There's a pinch. You can open this up. You can take the vibratory part out. And in this case, you can see the vibration comes from this flap that is activated with the exhalation into the device. When you put it back together, it only goes back in one way. This snaps back on. You put your mouthpiece back on. Another thing I like about, Another thing I like about the Aerobica, it works really well together with the Air Eclipse neb, the breath activated neb. You fit it right on the end. And if you have your neb set to the triangle with the dots, that's the breath activated. You can get both therapies. You can see the valve opening and closing. So you can use both therapies at the same time. The other devices especially the acapella and the VPEP, you could use with, maybe not this one, maybe a normal neb. You can use with a nebulizer as well if you wanted to. The VPEP is the same way. I could use that with a nebulizer if I wanted to as well. So that is nice. I just like that the Air Eclipse and the Aerobica go together and it's breath activated. So as far as this therapy, we would talk about goals of bronchial hygiene, which are mobilization of secretions, decrease work of breathing, and improve gas exchange. So those are our goals. Indications, there are a lot of indications for bronchial therapy or chest PT. Accumulated secretions, indications would be accumulated or excessive sputum secretions, ineffective cough, a history of a disease that would produce excessive sputum like cystic fibrosis, like bronchiectasis, abnormal breath sounds. So what would an abnormal breath sound be that would indicate excessive sputum or retained secretions? Bronchi, right? It might be kind of coarse crackles too, but bronchi is the main one that tells us that there's fluid in the larger airways, right? Abnormal chest x-ray as well. We would probably be looking for buzzwords like infiltrates, consolidation, that would indicate a patient may need bronchial hygiene. Okay, contraindications. We are talking about absolute and relative. So an absolute contraindication would be one in which we would decline the therapy. These apply, well, one of them probably applies more than the other for OPEP. So an unstable head or neck injury, we would not perform bronchial hygiene. Probably not OPEP, but, well, you wouldn't. The other absolute would be hemorrhage or active hemoptysis. So those are absolute, we would not do the therapy. The rest are relative, so we may perform the therapy with some modifications. Those include recent spinal surgery, recent pacemaker placement, or some other implantable, like a loop or a port or a newly placed line. You want to make sure that that's secure and in the right place before you would perform therapies. Emphysema, because these patients may have blebs or bullae that you could pop with the therapy. Increased ICP, I always joke with my students that is like a contraindication or hazard for almost everything we do. Hemodynamic instability, recent rib fracture, recent skin grafts in the area, pulmonary edema, osteoporosis, recent tube feeding or meal, and suspected or active TB. So the rest of those, they were relative, so you just would probably make accommodations. As far as hazards, increased ICP, there it is again. Hypoxemia, rib fractures, you could fracture their ribs. It's a contraindication and you could cause it. Increased airway resistance, hemorrhage, aspiration, bleeding and bruising, and exacerbation of irregularities in the skin. Burns, surgical sites, wounds, recently placed devices. So that covers that. We would, of course, make sure there's an order. We would review the patient chart, all of the normal things. Chief complaint, reason for admission, medical history, progress notes, orders, if there's orders outside of what you're there to perform. If they're getting a bronchodilator, you would probably give the bronchodilator before and then perform your therapy, or you could do both, right, at the same time. We would look for labs, ABGs, diagnostics. We would look at surgical history, occupational history, social history, all of the things that we would normally review in the chart for anything we're doing with our patient. It can include code history, it can include limb restrictions, not code history, code status. Course of treatment while they're there, plan for the day, all of the things you would look at in the chart. So then we're ready to come in. We have our order. We have information about the patient. We're going to sanitize and get gloves. Let me grab those. Of course, I'm checking my patient's armband, hopefully being able to verify it with my patient. Hi, Mr. Howell, I'm Jen from Respiratory. I'm here to do some therapy with you, but before we get started, can I check your armband? Can you tell me your name and your birthday? Patient would tell me name and birthday. I would verify it on the armband. Okay, Mr. Howell, I am going to assess you before we start this therapy. What are the things that I would assess for Mr. Howell? I would first visually inspect him. I'm probably doing that as I enter the room. So I am looking at what position he's in. Is he tripoding? Is he sitting comfortably in bed? I'm looking at his overall skin color. Is he diaphoretic? Does he have signs of cyanosis? Is he nasal flaring? Probably not in an adult. Does he have accessory muscle use or retractions? Sometimes you can see that. Even not everybody has a gown all the way up to their neck and a blanket all the way up to their neck. So you might be able to see that. I typically, when I come in, kind of give my patient's foot a squeeze as I go by to see if they have any pedal edema. I might be looking at digital clubbing when I'm looking at their armband. I would be either checking vitals or looking at vitals at the monitor. Of course, the vitals, the 5 vital signs are heart rate, respiratory rate, pulse ox, blood pressure, temperature. If I find a patient and I'm here and I'm assessing them and they feel warm to the touch, I might check their temperature. I'm going to listen to breath sounds. I'm going to palpate and I'm going to percuss. Specifically with bronchial hygiene, I'm probably palpating, feeling for bronchi fremitus, tactile fremitus. I might percuss over the areas. I would probably be looking for a dull note because that would indicate consolidation or something solid, and that would help me pinpoint the area where the patient may be having trouble in their lungs. Breath sounds, I may have already said this, we would be looking for bronchi, maybe coarse crackles that would indicate the area where the patient may be having a problem. It might be all over. I would ask the patient how they're feeling. I would assess a cough if they have one or ask them about a cough. I would assess sputum if they've brought some up. Many patients have their basin or their tissues laying right on their bedside table, so I would be looking for that. If I don't see anything, I would ask the patient if they've been coughing, if they've been bringing anything up. I don't use words like sputum. With a patient, I would probably say phlegm or secretions. If it's a little kid, you might say boogers. You have to match your level of communication to the patient, but you do not want to be using clinical terms like sputum. I think that pretty much covers my patient assessment. So once I've assessed him, I am going to explain the therapy to him. So I typically will start out with a patient asking Mr. Howell, Mr. Howell, I'm here to deliver some vibratory PEP therapy to you. It's a big word. It just means we're going to help keep your lungs open a little bit longer when you breathe out and shake them up to get the phlegm out. I would bring the device out and say, this is the device we're going to use. Have you used this before in the past? Assuming the patient says no, I'm going to give him the full education on the therapy. So I am going to tell Mr. Howell, okay, Mr. Howell, don't worry. We're going to explain. I'm going to tell you everything that you need to do, and I'm going to make sure you know how to use this. And then I'm even going to come back a little bit later and make sure that you're still able to use it effectively. Okay? So this is the device. This is a mouthpiece. If you've ever had a nebulizer with a mouthpiece, used a spacer for an inhaler or a pump with a mouthpiece, maybe even that incentives spirometry they want you to use while you're in the hospital, the one that moves up and down, that's the same kind of mouthpiece. So what you will do when you use this therapy, the first thing you're going to need to know is you're going to wrap your lips around the mouthpiece with a tight seal, like a whistle or like those other therapies if you've had those before. And I typically, if I'm able to, bring in a demo one that is mine so I can show them, especially if it's a new therapy for the patient and they've never had it. So what I'm going to do is pretend this is my demonstration device because Hal obviously is not going to be able to wrap his lips around a mouthpiece and perform the therapy because he's a mannequin. Okay, Mr. Howell, so that's the first thing we're going to need to know. We need to have a nice seal around the mouthpiece. Now, I can set different numbers on this device. The Aerobica, I can set the lower end to 1, the higher end to 5, and it makes it harder to breathe through and gives a stronger vibration. I like to start out in the middle and just see how it feels for you. We can adjust it down or we can adjust it up. So I'm going to put that there in the middle. And what you want to do is take a deep breath in through your nose. You're going to have your lips around the mouthpiece, and you're going to exhale through the mouthpiece. Keep your cheeks tight because you don't want to waste any of that pressure and puffed out cheeks. You want to keep your cheeks tight, and you want all of your air to go through the mouthpiece. When you exhale, it should be a more forceful exhale, but it doesn't have to be, it's going to make you take a longer exhale. That's part of what the device does. It helps keep your airways open. It gives you a little bit of pressure that's going to make you exhale longer so that you get the full effect, okay? So it should look like this. Do you hear that clicking or the vibration in there? That is what is going to work down into your airway and shake the sputum up. Oh, I said sputum. Shake the phlegm up and help get it out. It's going to physically shake it up. So a good therapy is to use this for, some people say 3 to 5 minutes, some people say 5 to 10 breaths. I like 10 breaths. You don't have to do them all in a row. If you start to feel lightheaded because you're breathing out for so long, just take a break, take a couple of breaths and try it again, okay? So it's gonna look like this again. Let me get closer for you. Okay, I'm gonna ask you to try it with your device, and I would give him his device. I would let him try it once and ask him if he felt, I usually say thumping in your chest. Did you feel that thumping? Was that okay for you? Was that too hard to breathe against? Was it too easy to breathe against? We can make an adjustment. Do another breath, and I'm gonna see if I can feel the vibrations because I should be able to feel them. And I usually just go like right kind of trachea sternum area. You'll be able to feel the vibrations. Okay, go ahead and take another breath, and I'm gonna see if I can feel it. That was great. How does that feel to you? We can always adjust it. Okay, now after we do this therapy, I'm gonna want you to do a nice big cough to try and get that phlegm out if it hasn't come up already. A good cough to use that is pretty easy for patients to understand, I think, is that forced expiratory technique or that huff cough. So you would educate your patient on a huff cough. Okay, this is gonna look funny. It's gonna look funny when I show it to you, but it really does help bring the phlegm up. So what you're gonna do is take a deep breath in through your nose, hold it for a few seconds, and then you're literally going to huff. So you're gonna open your mouth, do a couple of rounds of huffing. After 2 or 3 rounds, we're gonna do our cough. Take a deep breath and give a good cough effort. We are opening the airways with the huff, and then we're doing a nice forceful cough to try and get the phlegm out. You can add what we call chicken arms. Again, I know this all sounds funny. After you do your huffs and you're ready to cough, and you are literally using the force of your arms against your thoracic cavity against your chest. I wouldn't say thoracic cavity to a patient. Against your chest to help give it that little extra push. I even like to kind of curl up a little bit when I cough to shoot that diaphragm up a little bit. So after we use the device, we're gonna try for a big cough. And I would make sure my patient had, oh, where's my basin? It's disappeared. I would make sure my patient had a basin or a tissue or a Yankauer to cough their phlegm into. After the therapy, I would reassess all of the things we assessed in the beginning. Visual inspection, including color, signs of cyanosis, pursed lip breathing, nasal flaring, are they sweaty, what is their position. I would do palpation, either chest rise with my butterfly hands, feel for tactile fremitus. I would percuss over those areas. I would listen to breath sounds. I would check vitals. Always important is to ask the patient how they're feeling. It's patient subjective response. I would assess the cough. I would assess the sputum. Sputum characteristics that we're looking for are color, thickness, it may have an odor. So we would want to make sure to assess all of that as well, and the amount of the sputum. As far as documentation, you always start with date and time. You want to you may have to document what device you use. There may be a list of devices to choose from, or you type it in. You want to document the patient's effort. Were they able to follow directions? Do they need help every time they use this? How long did they use it? It might be how many breaths. It might be a time amount. You want to document your assessment, all of the things that we just assessed. Cough and sputum. I think that's about it. You would make sure that the device is clean. You would also inform the patient about how to clean the device. So you would show them if it comes apart. This one comes all apart. The mouthpiece comes off. I can take the top off. I promise I can. I can take the top off. The insides come out. You can actually see the flap there, so that's nice. I would show the patient that. I would probably show them more than once. A lot of people come in and talk to them. I always tell my patients, this is just what I say, you paid for this device, so I would take it home. It's a good device to have at home when you're sick, when you need to bring up more phlegm, and you can wash it with mild dish soap and let it air dry. I would tell this all to the patient, and then I would make sure that the device goes back. All of them come with like a little bag or something to keep them in. I would make sure the device goes back in the bag. I like it to be labeled for my patient, and put it in a safe place. If that's their bedside table, if it's their med drawer, if it's their closet, depending on if you're giving re-education the next time or not. And then I would make sure, as always, to leave my patient comfortable, ask them if they have any questions, if they need anything. I would make sure they have their call bell. I would make sure they're back in a comfortable position in the bed that's appropriate for them. And I would go, we already talked about documentation, but I would probably go document now, and leave the patient comfortable and happy. So that is vibratory PEP in a nutshell.